Good morning, everyone. Hello and welcome to today's breakfast at UMHealth, the 49th episode for the year 2021. Thank you for joining us for today's session. My name is Yoga and I shall be your moderator this morning. Before I introduce the speakers, I would like to cover a few housekeeping pointers. Today's session is being recorded and will be available in YouTube. We also invite your comments and your questions, so kindly drop your questions in the chat box or the Q&A box below, and I will pose them to the speakers at the end of the session. So cancer is no longer a stranger in today's day and age. It has affected most of us in one way or another. And I'm more than certain that each one of us were exposed to some sort of awareness campaigns at least once. However, many Malaysians are oblivious to the less common cancers. Bladder cancer is just one such example. It is among the urologic cancers with the poorest prognosis and is currently the 9th most common cancer in Malaysian men. That said, bladder cancer presents a number of challenges when choosing a course of treatment. And today we shall discuss the variables involved in this complex matter, both clinically and molecularly. With that, allow me to introduce the first speaker to you. Associate Prof. Dr. Shanggar Kuppusamy is a consultant urologist at the Department of Surgery at the Faculty of Medicine in Universiti of Malaya. Dr. Shanggar completed his clinical masters in surgery at the University of Malaya and his PhD in Bristol. Besides his clinical consultancy and academic responsibilities, as a fellow of the Malaysian Board of Urology, he upholds various roles in international organizations and is one of the esteemed urologists in the country. Over the years, Dr. Shanggar has been actively collaborating with molecular researchers in improving the management of bladder cancer and is an investigator in various grants. Today, he will be sharing with us on how does the molecular findings in bladder cancer chemoresistance assist in the clinical management of bladder cancer, especially muscle-invasive bladder cancer. With this, I hand over the floor to Dr. Shanggar.
Thank you very much, Yoga, for the kind introduction. I hope you can see my slide. And first of all, I would like to thank Breakfast at UMHealth for giving me this opportunity. And I would like to thank Dr. Akmarina, who is the second speaker today, and for inviting me to give a clinical overview and some of the challenges on how the research fraternity could help us in managing bladder cancer, and hence my topic today. And yeah, as introduced by Yoga, I'm Shanggar, and I'm one of the consultant urologists in the Department of Surgery in our hospital. Okay, so in the next 20 to 25 minutes, I hope to give a brief overview, trying to keep it as simple as possible, and also highlight some points where the researchers can help us in managing bladder cancer better. Okay, so first of all, I would like to introduce bladder cancer. What is it? It is, of course, cancer that arises from the tissues of the urinary bladder. It is made up of, it is called urothelial cells, made up of specialized transitional epithelial cells. And when the bladder is constantly exposed to environmental, potentially mutagenic agents that are filtered into the urine by the kidneys, they start to develop changes and become cancerous. And this is the picture on the bottom right corner is how a cancer of the bladder might look in a cystoscopic examination. So what is the disease burden of bladder cancer? It is the 10th most common cancer diagnosed worldwide. And as far as males are concerned, it is the 7th most common, whereby prostate cancer is second. And that explains why, bladder cancer does not get a lot of interest in research until lately, actually, because of the introduction of chemo and immunotherapy to the management. So, so being 9th or 10th in the world, it's about 4.4% of all cancer diagnosed. And as I mentioned, men are 3 times more likely than women to develop bladder cancer. It ranks 13th in the mortality of all cancer death, with 2.1% cancer death. And what about Malaysia? Malaysia, it ranks about 16th most common. So it is like one of those. If you take the Premier League of football, it might be very close to the relegation zone actually. So, but it is in Malaysia as well. It is highest. It is higher among males. In PPUM, just looking at our database before I started preparing the slides for today, I noticed that from 2010 to 2018, we had about 194 new cases, with 161 being males and 33 females. So I will just highlight a few important risk factor points for bladder cancer development. We can't do much about the non-modifiable risk, where the gender, males being more common, age, disease of the older people, and although hereditary and genetic component is not very well established, nevertheless, it is something to look into in the future when research components could be advanced. As far as the modifiable acquired risk factors are concerned, one of the most important risk factor is smoking, where smoking history is evident in almost 50% of bladder cancer that is diagnosed. The second most common one is the occupational exposure, with those who are in the paint, dye, petroleum industry are more susceptible to bladder cancer development because of their exposure to the aromatic amines and the rest. Some minor components in the risk factor is the environmental factor, where the exposure to arsenic in agriculturists, medical therapy, those who have undergone radiotherapy or cyclophosphamide in their treatment regime may be at risk as well. And those who are having chronic inflammation due to chronic cystitis of the bladder, bladder calculi, long-term indwelling urinary catheters are also susceptible. I mentioned schistosomiasis there. This is something that is very common in Northern Africa, where they are more prone to get this cystitis secondary to schistosomiasis, which is also very common in development of bladder cancer. Now, I just want to talk about smoking a little bit because it contributes about 50% of our bladder tumor cases. Smokers are having 2.5 times higher risk to get bladder cancer because there are carcinogens in the habit of smoking, where the beta-naphthalene and polycyclic aromatic hydrocarbon gets excreted in the kidneys, and once they indwell in the bladder because of stasis of urine in the bladder, then the potential of developing bladder cancer increases. And if someone starts smoking today, probably about 20 to 30 years down the line, the risk of developing bladder cancer becomes significant. And if you are to stop smoking, if you advise somebody to stop smoking, in order to advise somebody to stop smoking, you might want to use this, that you might want to mention to those people that you can reduce your development of bladder cancer by about 40% within 1 to 4 years. However, it takes about 20 years of cessation to become equivalent to non-smokers as far as the risk is concerned. Common pathology in bladder cancer, 90%, as I mentioned earlier, the transitional cell carcinoma is the commonest, with squamous carcinoma, because of schistosomiasis and inflammatory conditions, makes up about 5%, another 2% of adenocarcinoma type, and some rare tumors. I won't go into the details of TNM staging and all that and bog you down with very much with too much information. So I would just like to mention that the bladder cancer, of course, it starts in the mucosa. It can start as a carcinoma in situ, although it is an in situ malignancy, but the potential of developing high grade and rapid spread is very significant in carcinoma in situ. Is one of the important component in our management. And then it can go into the mucosa and submucosa layer, which is called TA. And then when it goes into the lamina propria, it's called T1. And then I've highlighted muscularis mucosa there. It will be labeled as T2 because the management drastically changes when it reaches this T2 level. And subsequently T3 when it invades the extravesical fat, and if it invades the adjacent organs, then it becomes T4. As in all malignancy, it can spread through the lymphatic system, through the obturators and para-aortic lymph nodes, and also spread hematogenously to become a metastatic disease. So in order to manage bladder cancer effectively, we would always classify them into non-muscle invasive. I would use the abbreviation NMIBC, and muscle invasive bladder cancer, MIBC. With the NMIBC being more common, 75% of all bladder cancer diagnosed at stage NMIBC. Okay, and this is this includes TIS, carcinoma in situ, TA and T1 up to the lamina propria infiltration. Then when we move on to muscle invasive bladder cancer, about 25%, it is from T2 and above, T2, T3 and T4. So this is just to remind you, when it invades the muscle, the extravesical fat and the adjacent structures. So it's very important for the management. Yeah. So as far as grading is concerned, when we get the pathology report, the older grading was grade 1, grade 2, and grade 3, where they look at the differentiation of the cells that was sent in the specimen. And now we are using the latest grading system where we grade it as a papillary urothelial neoplasm of low malignant potential, low grade, and high grade. So it is usually synonymous with the older grade 1, grade 2, grade 3. Yeah? Now, giving all this background information quickly, so I would just like to go on to the clinical presentation. How would a bladder cancer patient usually present? So they will usually present with frank hematuria most of the time. Yeah, more than 3/4 of the time it will be painless. So if it is a painless hematuria in the older age group, unless otherwise proven, this is actually bladder cancer most of the time. And they can also present with microscopic hematuria persistent in nature. Then studies have shown that almost 10 to 13% of patients with microscopic hematuria probably have an underlying bladder malignancy. So hence the need for urgent investigation and trying to pick up this condition. They can also present with associated non-specific lower urinary tract symptoms like recurrent infection, frequency, urgency, and nocturia. Right, once we have this kind of clinical presentation, what we would do is an ultrasound of the abdomen, transabdominal. It is a useful screening tool when somebody has hematuria. And apart from identifying renal tumors, we can also pick up bladder lesions when they are as big as this, actually. Yeah, so that is a bladder lesion in the bladder. And it can also give important information of an obstructive uropathy, where the tumor can block the urinary system and cause hydronephrosis. Of course, ultrasound, as we all know, is user dependent, and it only can identify bladder tumors if the bladder is well filled. Sometimes the bladder is empty, it's very difficult. And when the ultrasound says it's negative for any growth in the bladder, does not exclude bladder tumor, yeah, because we need to do another investigation, which I will come shortly. Now, if we, from the risk factors and history taking, if we identify a patient to be of high risk to be potentially a bladder cancer patient, we would then order a CT scan renal 4-phase protocol. Okay. Now, this is important in especially in patients with frank hematuria. Apart from being quite accurate in picking up upper tract urothelial malignancy, we can also pick up bladder lesions, which actually present with a filling defect in a contrast filled bladder. So when the contrast in the excretory phase, the contrast fills the bladder, and you will get a filling defect like this. Yeah, the lesion has to be large enough, of course. And CT scan is quite important and very useful because we can also get lymph node status information, and as well as the presence of any metastasis if we include the thorax as well. So now once we get a lesion like this, we would usually, this is actually enough to consider treatment by means of a transurethral resection of the bladder tumor called TURBT. Okay, so But before going there, let's say I said just now, if the imaging does not show any lesions, then we would then go on to do a flexible cystoscopy. This is standard of care. Okay, so we would go ahead and do a flexible cystoscopy, and the picture here shows how it is done. We would pass a cystoscope through the urinary meatus into the bladder. This can be done under the outpatient setting under local anesthesia. It is quite accurate to pick up any bladder lesion, and once a bladder lesion is found, then the patient will be subjected to a TURBT, okay, transurethral resection of bladder tumor. Now, transurethral resection of bladder tumor, TURBT, is very important because it is the first line of treatment for bladder cancer. Okay, so this is how it looks. The lesion, when we put in our resectoscope, we would resect the lesion with our U-shaped resectoscope, as you can see in the picture. And it is very essential that we get a complete resection. Okay, we need complete resection, but there are some drawbacks and difficulties that we face. Sometimes the lesions are big. We may not complete the lesion, the resection at one go. There may be thermal damage due to the electric current that we use, either monopolar or bipolar, and the pathologist might have difficulty reading because of this thermal damage to the specimen. Okay, and it is very important that when we resect, we try to get the muscle layer. Of course, not very difficult with the naked eye to identify, but we do try to go quite deep in order to include the muscle layer. As I mentioned earlier, muscle involvement is the clincher in the exact management of, is in order to stratify whether NMIBC or MIBC, and then the management actually changes. Right, so this is a busy slide, but I would not stick to this slide. I would just move on. Once the patient is identified as non-muscle invasive bladder cancer, NMIBC, we would then stratify them into low risk, intermediate risk, and high risk. Okay, because that helps us in managing the condition. So we have several low risk criteria that we use, and once that is identified, what we do is we will instill the patient coming out from theater. After coming out from theater, within 6 hours, we will instill intravesical chemotherapy in the form of mitomycin, okay, in the ward, and then discharge the patient once the hematuria settles, and do surveillance cystoscopy in following the protocol set out, 3 months, 1 year, right up to 5 years. If we get a patient with intermediate risk, then we would, because of the high probability of recurrences and progression to muscle invasive disease within 5 years, apart from the single intravesical chemotherapy, we might consider giving the chemotherapy to maintain the chemotherapy over a 1 year duration. Okay, and also together with the surveillance cystoscopy according to the protocol. Okay, the most important point here is to stratify a patient who is potentially a high risk bladder cancer patient, where the patient might have a T1 disease, high grade on histopathology, associated carcinoma in situ, or multiple lesions, size more than 3 centimeter lesions. Even though they are low grade, they're considered a high risk patient. Okay, recurrence and progression rates are quite high, and therefore we would usually subject this patient for a multidisciplinary team discussion, and may do a second look TURBT to make sure the muscle is not involved, okay, before deciding on the management, because if the muscle is involved, then it is indicated for a cystectomy already. So if there's no indication for a cystectomy, then we may use intravesical immunotherapy for patient in the form of BCG over a 2 to 3 year period, followed also together with the surveillance protocol. Now, just to recap, the mainstay of treatment of NMIBC, depending on the stratification of the risk, we would do repeated TURBTs, okay, include intravesical therapy with mitomycin or BCG. Mitomycin actually is a antibiotic chemotherapeutic agent which has got an effect on the DNA synthesis, and also BCG works as an immunotherapy. So we follow a strict surveillance protocol, try to identify recurrence and progression early so that we can modify our treatment plan, and always keep in mind patient may need radical cystectomy. The next block of patient is the muscle invasive and metastatic patient. So talk about muscle invasive first, MIBC. They can be from anything from T2 to T4 disease with absence of lymph nodes or metastasis. So when we get such a patient, we need to discuss with the patient whether the patient is agreeable to undergo radical cystectomy or not. If the patient is agreeable for radical cystectomy, then we can actually proceed to go ahead and do radical cystectomy upfront, actually. Yeah. So, but nowadays, with the advent of good chemotherapeutic regime, good response, getting proper improved life survival benefit by using neoadjuvant chemotherapy, especially the cisplatin-based chemotherapy, we would nowadays in our center we tend to give more neoadjuvant chemotherapy before proceeding to a radical cystectomy. So if the patient agrees for a radical cystectomy, they will undergo neoadjuvant chemotherapy most in our center preferably, and then for radical cystectomy. Okay, so if after the radical cystectomy and no neoadjuvant was given, then adjuvant chemotherapy can be considered. Okay, so let's say the patient do not agree for radical cystectomy. So what do? We follow the bladder sparing strategy. Okay, this includes regular TURBT to make sure the lesions are always flat. There's no recurrent lesions in the bladder, and patient will undergo chemoradiotherapy under our oncologist colleague. Okay, so this is a bladder sparing strategy. And if the patient comes with metastatic, then of course surgery has got not much role unless you would want to do a palliative cystectomy for or repeated TURBT for bleeding tumor. Otherwise, our oncology colleagues will use chemotherapy as well as immunotherapy, which is the newer treatment regime in the form of checkpoint inhibitors. Okay, so I won't go so deep into that because probably Akmal will go into this to look at the molecular impact of on these treatments. Now, why a patient might not agree to go for a radical cystectomy? Because of the reconstruction. So when we sometimes have lots of difficulty in convincing patient to undergo a radical cystectomy, because the reconstruction may involve the formation of an ileal conduit. What do I mean by ileal conduit? It is the isolation of a segment of the small bowel where we would attach the ureter, as shown in this picture here on the right, and attach it to the isolated small bowel segment and bring it out as a conduit. So the patient will actually pee in a urine, will actually excrete the urine into a urine bag, which they need to empty regularly. So there will be no continence actually. Yeah? So in a high volume center or in a younger patient, it may be considered to construct a neobladder, which is actually the same segment of small bowel we use. Of course, we take a longer segment and then reconstruct it into a bladder, attaching the ureter over the two horns of the intestine, as shown there. Actually, so this is sometimes a very difficult thing for patients to accept, and therefore they might when you are given an option of bladder sparing strategy, they tend to choose that pathway actually. So still, surgery should be always discussed with the patient as one of the as the first line of management if it is feasible. Now, I've given all the clinical picture as briefly as possible. And just would like to highlight a few issues that we have in the management where we may be, it may be helpful to get some input from the scientists actually. So first question to answer is whether screening is recommended in bladder cancer. You know, we have heard of colorectal malignancy being screened, having screening program, breast cancer screening program. Is routine screening for bladder cancer is not recommended. Why? Because we do not have a very accurate test. Okay, a test has to be quite accurate, and the incidence of bladder cancer, the ranking is quite low down, and the incidence is not very high in the general population. And there's a short lead time to diagnosis. So once the patient presents to get the diagnosis, it is quite quick, and the cost of already the cost of surveillance is very high with cystoscopy and all that. The cost of a diagnostic or a screening test might be very high as well. Yeah. So speaking about some issues that if I'm a clinician, if I get some input from some breakthrough research, I would like to get proper tests with high sensitivity and specificity, as we all know. So we have the urine cytology at the moment that we use regularly. It has got good sensitivity and specificity, but only in high grade and carcinoma in situ, we get good sensitivity and specificity. For the low grade diseases, which we would like to catch early and manage them early, the problem comes when the sensitivity and specificity is quite low. But there are, you know, as listed here, there are many screening tests that have been developed. However, compared to the urine cytology, although they have better sensitivity, the specificity is quite low. These tests are all, it all comes at a cost, and there's always an issue whether to use it for screening or to use it for follow-up or to try to stratify low risk or intermediate risk. There's always a lot of issues here. So as at present time, there is none of the tests available can replace cystoscopy actually. Yeah. So this is what we know at the moment as far as accuracy of the test is concerned. The second issue is whether I can avoid doing unnecessary cystoscopy during the surveillance. Okay, so whether if I have a particular test or particular biomarker that I can that I can avail, and I can actually prevent the frequency of the cystoscopy. You know, so why we want to do frequent cystoscopy? Because we want to pick up the high risk tumors or high risk recurrences early, so that we can intervene early. So at the moment, we do use this cystoscopy and urine cytology, but an ideal marker, you know, should detect recurrence early before they progress to muscle-invasive bladder cancer. So it, you know, at least it should be able to have a very high negative predictive values. You know, so if that test is positive, then definitely this patient will not progress. So that is or recur. Then that will help us a lot. Okay, and if you can cut down on the surveillance by using cheap tests, then you can reduce the healthcare costs. So at the moment, again, although many researches are going on, you know, there are some potential benefits, but no marker has been recommended to replace a follow-up cystoscopy or even reduce the frequency that has been set by the guidelines. Okay, in our management. Next is bladder cancer recurrence and progression. Okay, so the mainstay of treatment in NMIBC is, of course, to reduce the recurrence and to make sure we pick up any progression to prevent progression to MIBC by using intravesical therapy, either as a once-off post-op within 6 hours, or by inducing and maintaining them on intravesical chemotherapy for a particular period. So if we get a marker to identify whether a test that can identify that this patient may not respond to intravesical therapy accurately, you know, then you know, we may save the cost of using intravesical therapy unnecessarily. You know, so identifying a non-responder is a very good potential marker for us, and therefore we can actually modify our surveillance protocol for the patient. Next, and with this is the last point that I would like to make is what Dr. Akma is going to speak on, actually, because this is the use of chemotherapy has come into picture when we can use it as a neoadjuvant in a neoadjuvant setting, as well as in an adjuvant setting for patients who have undergone radical cystectomy. So, and also the new checkpoint inhibitors have come into the picture. So, and these regimes are used for MIBC and metastatic disease. So, identifying chemoresistance, so if we know a patient who is being planned for a radical cystectomy, and we are able to identify somebody who has who we know based on a marker that he or she may not respond to neoadjuvant chemotherapy, then we can proceed and do early intervention by radical cystectomy, so that we can we do not need to waste time and cost of chemotherapy on that patient. So as far as all these researches on biomarkers are concerned, lots of mixed findings, and it has not come to a regular clinical usage yet. And I'm sure Dr. Akma will be talking about this in depth on how the chemoresistance of chemotherapy may help in the management of muscle-invasive bladder cancer. So in summary, this is my last slide. You might have picked up from this presentation that bladder cancer management is quite complex, with multitude of treatment modalities, and everything changes based on stage and grade. And the issue with long-term surveillance, so which is very necessary, because recurrence rates are high, progression rates are very significant, and the management immediately changes from something that is more manageable and less morbid to the patient, to something very morbid like a radical cystectomy, which involves a lot of modification of lifestyle and all that. Yeah. So we are having limitations in the markers to help us manage the patient in a clinical setting. And all these markers may help us follow up the patient better and also choose the best treatment modality. So with that, I would like to thank you and for listening, and I will pass over to Yoga to introduce the next speaker, and we will take some question and answer if there are later. Thank you.
Thank you, Dr. Shanggar, for the wonderful information, actually. Before we move to our next speaker, questions are welcome, and please do drop them in the chat box or the Q&A box just below your screen. So our next speaker, Dr. Noor Akmarina Mohammad Said, is a senior lecturer at the Department of Pharmaceutical Life Sciences at the Faculty of Pharmacy. Dr. Akmarina is a pharmacist who completed her PhD in molecular biotechnology and pharmacogenetics at the Monash University, Australia. She has been researching molecular cancer biology to specifically improve treatment outcomes, and she is part of the Metastasis and Tumour Microenvironment Group at the Translational Core Laboratory, with a particular forte in microRNA work. She is also a principal investigator for various grants, such as the FRGS and IIRG grants, which see a lot of interdepartmental collaboration. So without further ado, I hand over the floor to Dr. Akmarina.
All right, thanks, Ms. Yoga. Let me just share my screen. Thank you, Ms. Yoga. Thank you to also the organizer of the breakfast at UMHealth, and as well as Prof. Shanggar for the very insightful talk. So I guess Prof. Shanggar has excellently described the background for bladder cancer and the management. My topic today, I hope it's not too complex. It is the tumor microenvironment-driven microRNAs in the chemoresistant of specifically muscle-invasive bladder cancer. So I know the audience come from diverse medical background, but I hope towards the presentation today, I'll be able to bring you to understand why this particular niche is of interest to us, and more importantly is what is the implication towards the management of bladder cancer. Okay, so Prof. Shanggar has externally covered the clinical aspect of the cancer, and we have been highlighted just now at how radical cystectomy is considered the gold standard for treatment in patients with muscle-invasive bladder cancer. And we also know that before radical cystectomy, the patients are usually given neoadjuvant chemotherapy, and this is because it is to improve the resectability of the cancer as well as to improve the overall survival. And when we talk about neoadjuvant chemotherapy, the cisplatin-based regimens are the one that is usually used. And this can be the MVAC regimen, methotrexate, vinblastine, doxorubicin, and cisplatin, or gemcitabine and cisplatin. Basically, both of them contain cisplatin. The current standard of care, correct me if I'm not wrong, usually is 12 weeks of chemotherapy before the radical cystectomy. Now, apart from the side effect, the toxicities, and the cost of the chemotherapy itself, we also have been highlighted at how patients can actually improve from the ability to predict the response. As of yet, there are no reliable method to predict the patient's response toward chemotherapy. So as implications, the patient might suffer from toxicities while they are ongoing chemotherapy without achieving the beneficial effects of the drugs. And this also would get the clinician to miss the opportunity to switch to another type of therapy when the patient's physical condition deteriorates. So if you can see the figures on my left here, this is just a depiction of the tumor, and you can see our desired outcome is the response to shrink the tumor, but there are, in some cases, the tumor just progressed. And when we talk about tumor response at the clinical setting, there are many criteria that can be used. There are WHO criteria or RECIST criteria, and both of these criteria actually is guided on the size of the tumor. I'm not very good at the clinical side, but what I know is not every institution employ this, and that is because it's hard to get the size of the tumor, especially when they are irregular in size. So it's not really easy to use. So different institutions might use different impression. For example, the thickness of bladder wall, the cystoscopy assessment, and other clinical symptoms. Now, at the clinical setting, we usually term it as treatment response. But we, at the molecular settings, we use the term chemoresistance. And in fact, the resistance towards cisplatin has been shown to be responsible for the low rate of response, and the response rates can be as low as less than 50%. And indeed, when the patients resist the treatment, they have actually poor prognosis and develop high recurrence rate. And as of currently, there is no good marker to identify these high-risk patients that can develop resistance. And although there have been decades of study to understand the mechanism of chemoresistance, the current understanding, especially at the intracellular level, failed to translate into clinical setting. So when we talk about chemoresistant, and when we talk about tumor cells as a single component, decades of study, like I said, we have been looking at all these factors that can contribute to chemoresistance. For example, you know how the drugs are pumped out of the cells with all these transporters, and we know that the molecules involved are, for example, CTR1, ATP7A, 7B, and we also know there's active DNA repair that is facilitated by PARP, ERCC1, and ER, as well as altered apoptotic machinery that is contributed by molecules such as BCL2A and p53. However, although all this has been extensively studied, limited success have been observed at the clinical forefront, and this makes us to think whether this monodimensional approach is sufficient to explain the complexity of chemoresistance. So it's a time where researchers now take a step back, and rather than look at the tumor cell as a single entity, we have to admit that tumor it doesn't live in isolation, but rather in close proximity, both literally and functionally with the neighboring cells. So all these neighboring cells, namely, for example, the cancer-associated fibroblasts, the endothelial cells, and the factors in the angiogenesis, all the immunomodulatory factors, the adipose stromal cells, all these have been shown to be cross-talking with the tumor cells to induce chemoresistance. So all these factors actually works in orchestra to facilitate chemoresistance. So it only makes sense that we study them as a whole. For example, when we talk about immunomodulatory molecules, for example, tumor-associated macrophage, we know that this is the most extensive host immune stromal cells in the tumor microenvironment, and they actually have two distinct phenotypes. But phenotype M2, which supports tumor progression, have been shown to be enriched in the particularly invasive subtype, and these have been shown to be caused by activation of cytokines and lead to chemoresistance and reduce overall survival. Besides the macrophages, the leukocyte as well. So this is the most abundant cytokine in the bladder tumor microenvironment, and all these interleukins such as interleukin 4, 10, 8, and 11 have been shown to recruit the macrophages in the tumor microenvironment. And in fact, IL-8 has been implicated in tumor motility and facilitate chemoresistance. And besides the macrophages, leukocytes, the chemokines, which is a secreted protein that help the migration of leukocyte, have also been shown to be involved in resistance. For example, these chemokine ligands 1, they recruit neutrophils, and these high infiltrating neutrophils have been shown to lead to poor survival for MIBC patients receiving cisplatin therapy. And other ligands such as CXCL12 and 4 has been shown to be involved as well. So that is at the immune inflammatory landscape. Other components of the tumor microenvironment, namely the cancer-associated fibroblasts. So this is a population of activated fibroblasts, and we know that these fibroblasts secrete variety of active factors to regulate tumorigenesis and chemoresistance. In fact, the curve have been shown to express and secrete TGF-beta at higher levels compared to benign fibroblasts, and this has been shown to positively correlate with poor outcomes in bladder cancer. And how do they do this? Cancer-associated fibroblasts have been shown to transport some epigenetic materials, namely microRNA, to the tumor cells, and in fact, this actually also impact the microRNA regulation in the tumor cells. So what is microRNA? So microRNAs are non-coding nucleotides, and it is involved in the gene regulation because, okay, you can see here in the diagram, the microRNA tends to bind to the complementary mRNA, and once it binds, it can cause mRNA degradation. So in the absence of the microRNA, the protein can be translated efficiently, but when there is mRNA and there's a complementary targeting mRNA, that can cause translational inhibition. So basically the function of microRNA is to fine-tune a large percentage of protein coding genes, and this has been shown to be also involved in tumorigenesis and chemoresistance. So microRNA, just like your gene, can function as oncogenic or tumor suppressor. Owing to the protein translational properties just now, if the microRNA is oncogenic, then it would target the tumor suppressor gene. And similarly, if the microRNA is tumor suppressive, it will augment this oncogene translation. And indeed, all this deregulation of microRNAs have been studied, especially at the intracellular chemoresistance level. So microRNAs have been shown to underlie all the regulation of intracellular mechanism of chemoresistance, both in tissue samples and also in cell lines. And you can see that there's various of microRNAs that have been found to be regulating all these chemoresistance mechanism. However, rather than It is worth also noting that the deregulation of microRNA in cancer is not only due to the protein translational inhibition that I mentioned just now. There are other mechanisms that are involved in regulating microRNA. For example, this reduced expression of microRNA 30A have been shown to induce resistance to gemcitabine and cisplatin via the targeting of gold pH3, then increased stemness. And it is also worth noting that one microRNA can be deregulated via different mechanisms. A good example is microRNA 193A3P here. It has been found to be highly methylated in bladder cancer, and at the same time, it represses various transcription factors such as HIT1, HOXA9. And if you can see here, this also shows that one microRNA can affect a lot of mRNA. So the regulation of microRNA, mRNA is quite complex because of the many downstream target genes. So back to tumor microenvironment just now, most of the microRNAs that have been identified so far are from the intracellular resistance perspective. When we are looking at the microRNAs regulated by the tumor microenvironment, studies are still limited. And you can see here, the listed microRNAs here actually comes only from the studies involving tumor-associated macrophage. So we talked just now how this macrophage, particularly M2, is highly expressed in invasive subtype of bladder cancer, and this has been shown to have positive correlation with these 7 microRNAs. In fact, separate studies on the individual microRNAs have found similar or parallel activities. For example, MIR155 have been shown to be highly expressed in the urine of tumor of recurrent bladder cancer patients, and it is also found to be associated with overall survival in bladder cancer patients. Another microRNA that have been identified from the tumor associated macrophage is 214, and separate studies have also shown that they can actually reduce cisplatin resistance, and this is associated with the high M2 infiltrations and advanced stage of bladder cancer. So like I said, all these come from this single study that look at the involvement of immune cells. But what about other components in the tumor microenvironment, namely the cancer-associated fibroblasts? We described just now how cancer-associated fibroblasts can induce chemoresistance, but what are the microRNAs involved? It is challenging to incorporate all tumor microenvironment components in a single study, so factoring individual tumor microenvironment components might allow specific profiling. So to delineate the role of CAF in modulating microRNA, and this is what our group is currently doing with the collaboration with Prof. Shanggar's and team. We get bladder cancer tissues from the patients, and we extracted cancer-associated fibroblasts from these tissues. And with the conditioned media of the cancer-associated fibroblasts, we expose our bladder cancer cell lines, both chemosensitive cell lines and chemoresistant cell lines, to this CAF, and we would like to see what are the microRNAs involved in CAF-mediated chemoresistance, and this will be done, this profiling will be done via nanostring assay. So all this, from the extraction of CAF from the bladder cancer tissues to the bioinformatics of nanostring assay, actually requires careful methodological approach. So one might ask, why bother with microRNAs? Of course, it's obvious that we want to target microRNA because it is a potential candidate for MIR-based therapy. When we can target microRNAs, we can either suppress it or we can either overexpress it. So as you can see here, AMO is anti-MIR oligonucleotides. And this approach, along with microRNA sponges, microRNA masking, are different approaches that can be taken to reduce the microRNA expression. And if the microRNA is actually desired towards your biology, then you would want to overexpress it using microRNA mimicry. But all these are all this development of miR-based therapy is of course comes with paramount challenges, but that's, for example, how to deliver into the cells, how do you protect it from all the enzymes in the body, but that's another topic of discussion. So basically, we want to identify the microRNAs, particularly that is involved in chemoresistance mediated by cough due to this purpose. Now, earlier on, we also talked about how it is of value to be able to predict the effectiveness of specific therapy, because this would help the clinician whether to discontinue the chemotherapy at early phase, proceed to surgery, so we reduce unnecessary morbidity and improve the quality life of the patient. So along this line, we also have another study going on to predict the response and treatment response. And this is guided by this molecule of interest called FDFT1. So FDFT1, we hypothesize that is involved in maintaining the sensitivity towards cisplatin and bladder cancer, and using bioinformatics and wet lab approach to identify what are the microRNAs modulating FDFT1. We are interested to see if these microRNA are indeed differentially regulated in tissues from resistant bladder cancer patients as well as sensitive bladder cancer patients. So as a whole, the point that I want to make here that we need to take all this tumor microenvironment into consideration when we are talking about tumor resistance. And just like the saying, good fences make good neighbors, we need to build a fence to somehow intervene with all the factors secreted by all these tumor microenvironments, so the tumors won't be able to progress and later resist the treatment. That's all from me. And this is our Metastasis and Tumor Microenvironment Research Group. And we are both from Faculty of Pharmacy and Faculty of Medicine. I think that's all from me. Thank you.
Thank you, Dr. Akmarina. I see that we do not have any questions in the chat box. Dear audience, please drop any questions if you do have any, and we will get through as many as we can with the limited time that we have. Meanwhile, while we are waiting for them to just drop the questions in, this is a question maybe to both Dr. Akmarina and Prof. Shanggar. So both of you have mentioned how we do need some molecular markers to help us with the clinical management of bladder cancer. So we have also seen a lot of research out there that has been conducted using patient tissue samples and whatever not. So how do you think we can move forward? So is it because we also know from Prof. Shanggar earlier that he mentioned that when we actually perform the TURBT, or we actually, the samples undergo thermal damage. So is there any other possibility for us to gain samples and then perform molecular profiling for us to gauge the bigger picture?
Akma, I go first because you are asking whether to improve sample acquisition, is it?
Yeah.
To improve sample acquisition, of course.
Yeah.
This is a problem actually, because the entire sample that we collect from the patient when we do the TURBT is actually, the primary goal is to establish the diagnosis and the depth of invasion.
Right.
Okay. So to use this sample to actually submit some of this sample for research purposes may not sound very ethical actually. You know, a fresh sample from this lump of tissue that we resect from the bladder, isn't it?
Right.
Because the sample that we submit to the pathologist may contain the muscle that is involved and may not be picked up in the clinical diagnosis, and the patient may be undertreated hence, isn't it? So that's why the limitation of this thing. Should the research, most of the research conducted for this kind of studies, mainly, probably maybe Akmal will agree with me, it is all FFPE based research from the slides, try to extract markers from the slides that are already been read by the pathologists and all that, so that's the difficulty, and that's the limitation, and that is my opinion. Of course, we are trying to get like en bloc resection, where we get the entire tissue in one go without doing piecemeal resection. All these are in practice, in clinical scenario, but still the difficulty is what I mentioned. I'm not sure what Akma thinks.
Okay, thank you, Doctor.
Yeah, I'm in agreement with Prof. Shanggar as well. I think because we also have been working on this, right? It's hard to get sufficient samples, so we just have to be kind of creative on how we can explore the molecular questions. Yeah.
Okay. All right. Just 1 minute. Okay, so we do have a couple of questions. The first question is directed to Dr. Akmarina. Has microRNA been used as the diagnostic and prognostic marker for cancer patients in the clinical setting?
So as for both MIR-based therapy for the diagnostic and prognostic marker, as well as MIR-based therapy as anti-MIR and microRNA mimics, as far as I know, there's not yet that have been used at the clinical settings, but there are several that are in the clinical trials, both at the phase 1 and 2 level, as well as the preclinical levels. There are in the clinical trials level, but especially in bladder, there has not yet been any that have been translated to and has been used in the clinical settings. Yeah.
All right. Thank you, Dr. Akma. So the next question comes from Dr. Gauri. How about blood and urine markers or virtual-based models before using samples? So I think virtual-based models, I think she might be talking about 3D in vitro work, I think, or bioinformatics modeling.
First about the urine and blood thing. Yeah, that is the most. That is when it will come into use in a clinical setting. Just answering the previous question and answer by Dr. Akma. That is when we can establish something that can be translated from the molecular level, tissue level into the blood and urine, and that's when we expect a breakthrough finding that can be used in a clinical setting, because then it becomes very less invasive to obtain a sample. Urine is very easily available. We can draw blood. Screening tools are regularly in the blood, actually. So that is when it will all move towards some breakthrough finding in the bladder cancer. I foresee. At the moment, of course, we have all those urine cytology and all NMP22, which I mentioned earlier. Some of it are urine based, but still the accuracy, accuracy is not so great at the moment.
Right.
Artificial intelligence use, virtual modeling and all that, it will be great actually, but I'm not sure I'm well knowledgeable to comment on this, but of course, anything that can help us in a clinical management will be helpful.
Yeah. And talking about liquid biopsy as well, the other thing that interests us on microRNA, because microRNA can be easily extracted from all these liquid biopsies. Although, the validation is quite challenging, but microRNA, because the nature of it is quite stable and it can be extracted. But the thing with microRNA to be used as a biomarker in urine or blood, rather than, because how microRNAs, one microRNA can impact a lot of mRNA. So some people have suggested that rather than to use one single microRNA, is to use a panel of microRNA to guide all this, treatment, the management, to which route do we want to go for the treatment. So it is actually some groups are searching on the microRNAs from blood and urine. And when we talk about virtual-based model, that is a very interesting field to explore actually. And of course, it needs a collaboration with the computer people. But yeah, that's a very interesting perspective.
Yeah, I think that's an upcoming pathway in cancer biology, isn't it? Okay, so I think, thank you, Dr. Akmarina and Prof. Shanggar. This would be the last question, I think, for today's session by Dr. Arvind. Can you give both mitomycin and cisplatin for neoadjuvant chemo? If not, how do you choose?
Okay, mitomycin is for intravesical therapy actually, and it is not given for muscle-invasive bladder cancer. It is for non-muscle invasive bladder cancer. In non-muscle invasive bladder cancer context, it is given as an intravesical regime.
Right.
The moment the patient needs systemic chemotherapy in the neoadjuvant setting, then mitomycin does not come into the picture. And in the current clinical scenario, we only use cisplatin-based chemo. So there's no need to make there's no necessity to make the differentiation or selection to include the possibility of using mitomycin in a systemic setting.
Okay.
So it's only in the intravesical setting.
Right. Okay. All right, then. I think that's all questions that we have for today. Thank you, everyone who joined us for today's webinar. Dr. Shanggar and Dr. Akmal, thank you for sharing your insight and expertise. And if anyone out there has any additional questions or would like to connect directly with either one of them, please do reach out directly or use the contact information on Expert. Thank you for your time, everyone. Thank you.
Thank you.
Thank you.
Thanks, Shanggar. Thanks, Yoga.
Thank you.
Thank you.
Thank you. Bye.